We're here at the conference on AIDS at the International Conference in Vancouver, BC, and we're here with Bohdon Nosyk, Associate Professor of St. Paul's Hospital, Canfar Chair in HIV/AIDS Research at Simon Fraser University, and Research Scientist in Health Economics at the BC Center for Excellence in HIV/AIDS. So, Bohdon, I really appreciate you taking the time to come to us. But I had a question at the press conference about the economics of this whole thing, about the wonderful results we have and how good the science is and how perfect the science is about prevention and so forth, and getting on treatment early, and pre-exposure prophylaxis and so forth. But it's gotta be, the numbers have to be right.
Absolutely, it's got to work to be sustainable.
And I know that Julio put me on to you because I'm sure he tapped your brain a lot for this information.
It's an important question that he's facing, that we're facing every day.
Right.
Is it good value for money, what we're doing? Is it going to save us in the long run?
Right.
And it's a very reasonable question.
And this is exactly what you're here to do, because I asked the question, I was the last question of the day, and I think I started a whole version of what we could talk about. But it is always interesting at press conferences what the press wants to hear, and I think for me this was the most important, because it's the bottom line. It's the bottom line for governments,
That's right. Even it's the bottom line for decision makers.
Even for like municipalities that have to say, where should we put our money? Prevention, whatever. But if we're talking about health, obviously we want the health of the community, and we also want the economics of the community. So tell us how you go about doing this, getting the numbers for these questions.
Right. Well, in this case, this was sort of a specific instance where our government, the BC Ministry of Health, came to us and asked the question, is what we've done in terms of scaling up antiretroviral treatment in this province, is what we've done, has it been cost effective? Has it been good value for money? We had access to some of the best data resources in the world to answer this question. What we did was we used all that information, we packed as much of it as we could into what's called a simulation model. And we reconstructed the HIV epidemic as it occurred in BC between 1996 and 2010.
It was retrospective.
It is retrospective, and then asked the question, had we done less? What if we had scaled up treatment to a lesser extent? Would we be better off? Would it have been better value compared to what we had done? And we found unequivocally the answer is no. What we had done is highly cost effective. So it's very good value for money, even if you're only considering the perspective of the Ministry of Health. And we know this disease
and then there's the economics of the individual.
Right, so we know there are productivity gains when you are successfully sustained on antiretroviral treatment. And of course, when I say good value for money, I mean the health benefits that you derive from it are within a reasonable willingness to pay. So when you account for the productivity gains, it actually becomes cost saving. So the increased expenditure you have on antiretrovirals are more than offset by delayed or eliminated need for hospitalizations, productivity gains, and fewer transmissions, right? Fewer infections, and that's those are the three-prong. That's the three-prong approach to antiretroviral treatment. It's about decreasing morbidity, mortality, and transmission, and that's what we're seing.
Right. So there's numbers. You have to look in all the different directions.
That's right. It's a multifaceted. It's a multifaceted problem, and it's an epidemic, right? So we accounted for that interconnectedness.
It's why I think we're seeing so much, because there's such a proliferation of death and dying in Africa, why we say such a devastated economic situation there, and why they're now shifting to a better prospect for a future, not only for the people, but for the country itself. for the infrastructure and so forth. I mean, you don't have that kind of devastation in our
That's
country.
right. I mean, it's, our prevalence rates are much lower, so you don't see that kind of same macro impact, but certainly...
And a more robust economy here, of course.
But certainly in, in settings where prevalence is 25, 30, 35%, you're definitely going to have an impact on the labor market as a whole.
So how much of this kind of activity like you deployed would we have to, or would have to happen to resoundingly impress maybe it's an open-ended question, I don't know, but
to me, it's not some kind of threshold level. It's whatever you can do to expand treatment, expand testing, there will be value in that. And I'm not saying,
because there are people that are being tested, that aren't being tested today, that are living a pretty debilitated life, and they don't know why. Or maybe they're being tested and they're falling out of care.
And they may be transmitting to their partners, and that has a huge impact as well, right?
So the quicker we can get, and I think that's always been Julio's main goal, is to get more and more people tested.
Right.
Everyone should be tested.
Right.
And then the amount of retesting is just based upon their associated risk, individual risk.
And the approach now is to really focus in on what we're calling localized microepidemics. So every urban center, every region has a different mix of people living with HIV/AIDS and a different kind of epidemic profile. And you really want to cater your services to those to the specific needs of your communities. And that's the approach that PEPFAR is taking now. You're seeing this kind of approach happening in both African countries where you have endemic HIV, as well as North American cities where you have concentrated epidemics. So that's where this is leading. So we're using our model now to look at a different mix of interventions. Do we target HIV testing campaigns in young MSM, and also focus on antiretroviral uptake among IDU, right? So what is the optimal mix of how we deploy our resources?
So the effort that you made was mostly for right here in Vancouver.
That's right.
But can that model be done in a retrospective for others, in just inserting different numbers? How does that work?
Yeah, so it was, I mean, the model structure, we actually adapted an existing model that was built for the US and had already been adapted for China. And
I see. You changed the model for China based upon their economic situation and all the other factors.
That's right, based upon the underlying conditions in the specific setting. So we built it, for a retrospective period initially, but once that is set, you can project forward,
prospectively, right? Okay.
Is
that what you want to do? Is you want to continue?
Yeah, I mean, we had this question posed to us, a retrospective question posed to us. I think we answered it quite conclusively. We did it with the best possible data that we could. And we took into account, all of the factors that we could about the epidemic, including changes in behavioral risk patterns. Now we've built this robust model. We can look into the future, and we can use it as a platform for adaptations for different cities and different locations. And that's what we're doing.
So. We don't have to do it for every single city. We can say, okay, your city is just kind of like this city, a partner city or something. I mean, you can't do it for every one, can you?
I think you can.
Oh, really?
I think you can. So these kind of modeling frameworks, I'm not the only one working on this. This is something that a lot of different groups all over the world are doing. And once you build it, if you can make it open source, and if you can make it available to anybody who needs it.
Plug in your numbers, answer the question.
That's right, get the answers that you need.
How much money are we going to save?
That's right, and where should our money be? Where should our money go?
Yeah.
That's the question.
How do we, so we would ostensibly be competing with other health issues in a way. But there is this issue of the drama that, now it's maybe a lot different now, but the people that are not being treated are going down the pathway that everyone else did that didn't have treatment. And so why do we want to let people go to that devastated point in their health or lack of health rather than being treated in advance and living a much healthier, with a better viral set point, et cetera. So the quicker we get people treated, the lower the viral set point, the longer that person is probably going to live.
Right.
And
And
the
that's,
healthier
and
that
that's
person
what
can live.
treatment as prevention is all
Yeah.
about, right? Seek, test, treat, and
So
retain.
it's the
as soon as you
90-90-90,
can.
yeah.
That's right.
Yeah,
And
yeah.
so 90% of all infected diagnosed, 90% of those diagnosed on treatment, 90% of those on treatment who are virally suppressed.
And then-
That's focusing on a cascade of HIV care, which takes into account that not only are we losing people to the care system, but we're losing them at different stages, and that's really sort of solidified the focus on what we need to be doing, how we need to be intervening, right? And the next step is then using these models to determine, what is the optimal mix.
So is it your goal to do an open source model?
It
Yeah?
is.
So is that maybe
something
what
that
you're
we're
doing
working
tomorrow?
on.
or-
Well, it's something that we're working on right now, and we want to do this for our the various regions of British Columbia, but we also want to take it and expand it internationally. I think there's a scope for doing that, and
You'll be making Julio proud to get that going.
Well,
'Cause I think he wants this to be a worldwide thing.
yeah, I mean, we're all on the same page. We're all inspired by his leadership, but we all want to do good, and we see that there's this golden opportunity to make a big
Right
change.
now, right at this
Yeah.
moment, we have this. We're going to use this as a launching pad.
Yeah.
Because Vancouver was a moment back in '96. We have this moment that was in treatment. Now we have prevention, and treatment, and there's a blur between the two. I mean, it's one is the other. It's all about getting people treated and getting people informed and getting people into wherever they need to be, wrapped around the model of what we know about HIV.
It's exciting to watch the field kind of change over the last 3-4 years even. It's been dramatic, and it really feels like now everybody's on the same page and we see what needs to be done. And the implementation work that's happening now, like I said, in third world countries, in first world countries, second world countries, it's pretty phenomenal. It's great to see.
In our country, in the U.S., we have a lot of places that are in the dark ages. I really hate to say that, but it's the fact. We don't have people being treated the way they should be, and it's a lot of. I think the biggest problem we have is the issues of criminalization of people who are living with HIV because they presume how they got it. The other is the stigma which people live with, and some countries are just so backwards. And so I think there's a lot of, like with CITAB, there's a lot of work that has to be done. Also with World Health Organization, with Gottfried in his presentation this morning. But with leadership like that, I think we'll move along, and hopefully you can back up the leadership with the data.
We're hopeful.
And that's, and don't be shy.
I hope that the economic argument, if nothing else, can,
If
speak
nothing
to a
else matters,
broader,
if you have no care about the humanity and you just
Well-
care about the bottom dollar, as awful as that sounds, hey,
whatever the point is, whatever way you frame it, this makes sense.
every direction,
Right?
yeah, it really does. Bohdon, I really appreciate you being here.
It's my
You've
pleasure.
been very helpful. And as an your name again?
An economist, health economist.
Health economist. I
Yes.
love that term because it's about that, and it's about being healthy. So I appreciate your time.
Thank you.
Thank you very much.
Okay.